Low flow. It's 6:31. Shall we formally start?
Yes, sir.
Yes.
Monica, you overtake now. You just.
Yes, sir. Thank you, sir. So a very good evening, everyone. We welcome you all to ISA online PG classes. The topic for today is breathing systems and gas laws in anesthesia. And to discuss that we have our eminent speaker, Dr. Tushar Bhavar.
Good evening, everyone.
Just a second, sir. Just a second. Can you see my screen, sir?
No, Monica is not visible.
Yeah. Dr. Tushar?
Yes, ma'am.
Is a professor in Department of Anesthesiology and Critical Care at DBVP, RMC and PIMS in Loni, Maharashtra. He is MBBS, MD, DNB and IDCCM, and he has a 13 years of teaching experience and more than 20 publications in national and international journals. His area of interest include critical care, pediatric anesthesia, echocardiography, and he conducts BLS and ACLS workshops too. Welcome, sir. As our chairperson, we have Dr. Madhuri. Ma'am is professor and head Department of Anesthesia, Karnataka Institute of Medical Sciences, Hubli. And she's an associate editor, Indian Journal of Anesthesia, and assistant editor in GOACP. Ma'am is PG teacher since 26 years now and has been a PG examiner. She has 90 indexed articles, 1 book, and 4 book chapters. And she has done advanced course in medical education too. She has been awarded as IJA Best Peer Reviewer Award in 2016-17 and ISA Proficiency Award in 2021. Ma'am's areas of interest include medical education and research. I welcome you, ma'am. So we'll be beginning our class now, and during the course of the lecture, everyone will be muted. You can type your queries in the chat box, and we'll take up all the queries at the end of the lecture. Sir, to just help you, Dr. Tushar, I'll be reading the MCQs or any questions you have during the course of the lecture. Over to you, Tushar, sir. So you can start sharing your screen.
So good evening,
Yes,
everyone. Good evening, all the participants. I would like to thank ISA team for giving me the opportunity. Special thanks to Dr. Bhavar sir for giving me this opportunity. So today's topic of discussion is breathing circuit, breathing systems and gas laws. So we'll try and cover all these breathing systems. Basically, we'll go in depth and about Mapleson system and circle system. As sir said, circle system and low flow anesthesia will be covered in next topic. So I will just run through circle system, but in-depth analysis, in-depth knowledge of Mapleson system will be shared, and also some basic gas laws will be discussed. So to start with, what is the breathing system? It is a breathing system is defined as an assembly of components which connects the patient's airway to the anesthesia machine. So it creates an artificial environment wherein a desired concentration and amount of gas is supplied from the machine to the patient. Okay. So to start with the history of breathing system, if we go into history, it starts from 1846 itself, when WTG Morton used his Morton bulb for ether anesthesia. Afterwards, John Simpson used chloroform for anesthesia. So there are multiple multiple inventions had occurred in breathing system. So main inventions are in 1930, this closed circuit was invented by Brian Swart. And in 1954, all the available circuits at that time were classified. All the available semi-open circuits were classified by Mapleson into 5 Mapleson circuits. After that, a coaxial modification was done by Baines in 1972, and JR circuit was included in Mapleson in 1975. In 1978, universal F circuit was invented. So what are the characteristics of an ideal breathing circuit? This circuit should deliver the gases in same concentration and in shortest possible time. It should be able to effectively eliminate carbon dioxide. It should have minimal apparatus dead space, and it should have low resistance. Also, there should be conservation of heat and humidification of inspired gas. This circuit should be lightweight. It should be effective during all spontaneous as well as controlled ventilation. It should be adaptable to adult, child, and mechanical ventilation during mechanical ventilation also. And there should be less of theta pollution. So it's very difficult to get an ideal breathing system. So what are the components of breathing system? It includes delivery tube, which the fresh gases are delivered from machine to the fresh gas entry point of breathing system. Breathing tubes, reservoir bag, pressure relieving valve, sleeves connector, adapter, CO2 absorber, humidification system, HME filters, gas sampling ports, and many more. There can be many add-on features according to the provided by the workstation people. So the breathing tube, normally it is of 20 mm, 22 mm of diameter, and 1 meter tube will have a volume of around 450 ml. So going to classification, there are multiple classifications like drips classification, Conway's classification, Baraka's classification. We will see these two classifications, that is drips and Conway's classification. In drips classification, this system has been classified in four groups, that is open circuits, semi-open, semi-closed, and closed. In open breathing systems, there is no reservoir bag, there is no functional rebreathing of exhaled gas, and there is no tubing and valves. So examples are insufflation technique and open anesthesia system. In semi-open system, we have a reservoir breathing bag, but there is no functional rebreathing of exhaled gases, provided there is a sufficient high fresh gas flow. So the examples are Mapleson breathing systems. Next comes semi-closed circuits. These are a closed circuit with partially open APL valve. Over here, rebreathing occurs, and there are presence of unidirectional valve. There is a system of neutralizing the CO2, that is CO2 absorber is present in these systems, and the fresh gas flow required is low. And in closed system, the circle system with CO2 absorber and very low flow of anesthesia will be classified as closed system. According to various other classifications, Mapleson breathing system in some classification is included in semi-open, in some it is included in semi-closed. If you follow drips classification, it is included in semi-open classification. Next way of classifying the breathing systems is Conway's classification, in which this system has been classified as breathing system with CO2 absorber and breathing system without CO2 absorber. So again, this is subclassified as unidirectional flow and bidirectional flow. So in case of unidirectional flow, the examples of unidirectional flow breathing system with CO2 absorber is circle system with absorber. Okay, and bidirectional flow system is to and fro system, that is water to and fro system with water canister attached, which has a CO2 absorber capacity. So coming to breathing system without CO2 absorber, unidirectional flow system are non-breathing systems. These are mainly used for resuscitation purpose, like ambu bag, and circle system without CO2 absorber. It will be included in breathing system without CO2 absorber with unidirectional flow. Bidirectional systems are further classified as afferent reservoir systems and efferent reservoir system. This we will be discussing during discussing the Mapleson system. So afferent reservoir system and afferent reservoir system are Mapleson A, B, and C, and efferent reservoir system are Mapleson D, E, and F. So coming to open breathing system, this is Schimmelberg's mask. These are Mapleson systems, that is semi-open system and closed breathing system. So semi-open breathing system, Mapleson had classified it as to be A, B, C, D, and E. These are the 5 classification Mapleson had given. Then Mapleson F was added later on. So what is the afferent limb? According to the classification, if we see that those are divided into afferent reservoir system and efferent reservoir system. So A, B, and C, if we look into the slides, those are having apial wall at the patient end. So the efferent limb is from patient till the apial wall. So mainly the fresh gas flow reserve occurs in the afferent limb. Afferent limb is the limb in which the fresh gas flows from machine to the patient. So the reservoir system over here is in afferent limb. So Mapleson A, Mapleson B, this will be the reservoir, and in Mapleson C, this will be the reservoir. These are the afferent reservoir systems. Efferent limb is very short, that is from the apial wall to the patient. So in case of Mapleson A, B, C, these are afferent reservoir systems. Mapleson D has a fresh gas flow near the patient end. So these are the basically these are similar to TPs of all these 3 systems, and they are having exhalation port. In case of Mapleson D, it has apial wall. In case of Mapleson E, it has open end, and Mapleson F, it has an open end of the bag at the opposite end, at the afferent limb. So these are the efferent limb, sorry. So these are the efferent reservoir systems, that is Mapleson D, E, and F. So these are this is about the classification of Mapleson system. Now coming to closed breathing system, these are having a CO2 absorber, and the exhaled gas is reused after passing through CO2 absorber. Exhaled gas is reused. This is the closed breathing system. So we'll go for in detail about Mapleson breathing system. Mapleson A, also known as Magill's, was invented by Magill's. So this is a system. This is a system which has a pressure relieving apial wall at the patient end, a corrugated tubing which is around 110 centimeters of the length, which can accommodate a gas of 1 tadalone, that is about 500 ml, and it has a reservoir bag at the machine end. So it has a fresh gas flow point at the machine end, and it is an afferent reservoir system. Okay, so it has an expiratory wall at the patient end. This expiratory wall is of, it brings types of expiratory wall. So going to the functional analysis of Mapleson A breathing system, we have to just first of all understand that during spontaneous ventilation, we will be keeping this apial wall open. So apial wall will be open during spontaneous breathing, and it will be partially closed during controlled breathings, okay, or assisted breaths. So during spontaneous breaths, the venting out of the gases will occur during expiratory phase, because during expiratory phase, there will be positive pressure generated in the circuit, which will cause opening up of the expiratory valve. And during inspiration, most of the times, apial valve will be closed. So if we, and vice versa is true for controlled breaths or assisted breaths, wherein positive pressure will be generated during inspiration, that is, we will be generating a positive pressure during inspiration. So apial valve will be opening in inspiration for controlled breathing. So if you concentrate on spontaneous breathing, functional analysis of Mapleson A. So in late part of expiration, most of the fresh gas flow will be delivered to the patient. In early phase of expiration, at the machine end, we are having a fresh gas flow, and during early part of expiration, this tubing and reservoir system will be filled with dead space gas earlier at the start, and at the later part, the alveolar gas will be filling the circuit. So during late part of the expiration, that is expiratory pause phase, the fresh gas flow will continue, which will and also the APL valve will open whenever a particular pressure is attained, which will cause venting out of the alveolar gas preferentially. So alveolar gas will be vented out preferentially in spontaneous breaths during late part of the expiratory. And in next inspiration, according to the amount of fresh gas flow which is flowing, there will be some rebreathing or no rebreathing. So with the different flows, if we are having high flow, then most of the dead space and alveolar gas will be vented out, and late part of the exhalation, that is expiratory pause time, even fresh gas will be vented out in case of spontaneous breathing. If we are using an intermittent flow, then most of the alveolar gas will be vented out. Some of the dead space gas will also be vented out, and patient will have adequate fresh gas flow during in inspiratory phase. If you are using too low flow, then during expiratory pause phase, that is late part of the expiration, it will not be able to vent out even the alveolar gas. So there are chances of rebreathing in Mapleson A also during spontaneous breathing also. So I think everyone has got Mapleson A breathing system, spontaneous Mapleson A functional analysis during spontaneous ventilation. So during spontaneous ventilation, we have to keep the APL valve open, but it has a internal pressure itself. APL valve has a internal pressure of at least 0.5 to 1 centimeter of water, so that the reservoir bag, which has a collapsing pressure of 0.25 centimeters of water, reservoir bag doesn't collapse. So that reservoir bag is filled. For that purpose, we are having a inbuilt pressure of APL valve. Okay, moving to controlled ventilation for Mappleson's breathing system. As discussed earlier, the venting out of the gas occurs during inspiratory phase, because during inspiratory phase in controlled ventilation, we will be generating a positive pressure, and venting out will occur after a particular pressure is attained. Okay. So late part of the inspiration, we will be having a good amount of fresh gas flow going to patient. In case of expiratory phase, there will be all this alveolar gas will be filled in the corrugated tubing, and dead space and alveolar gas will also reach the reservoir bag. So during next inspiration, there are chances that there will be rebreathing of alveolar and dead space gas. So this system, that is Mapleson A system, is not considered to be good for controlled ventilation because there are high chances of rebreathing of the gases. So to avoid or to minimize the rebreathing, the gas flows has to be kept high. So it is recommended to keep at least 2 to 3 times the minute ventilation. We have to keep the fresh gas flow rate. Okay. So what are the advantages of Mapleson? It is best circuit for spontaneous breathing. It has minimal wastage of gas during spontaneous, and there is minimal or no rebreathing if at least 1 minute ventilation of spontaneous, 1 minute ventilation of fresh gas flow is kept during spontaneous. But it is not good for controlled ventilation. Again, the expiratory valve is placed at the patient end, so it is difficult to manage, difficult to scavenge, and also being heavy, it has a risk of disconnection and all those things. So, and also it is not suitable for pediatric use. So this Mapleson A breathing system is not used routinely right now. Okay. So this is question for public, all the students. Can anyone identify this circuit? To give you a clue, we have this inner tube is connected to this wall. This is APL wall, and in lower diagram we have shown that inner tube has a expiratory wall over here. So to give you some more clues, so there are some wrong and some have given right answers. So we
So, answers are coming in.
Yeah.
Dr. Sonal, Dr. Asha has said Bain circuit. Then some of them have Dr. Shubhangi, Dr. Prabhakar, they are saying lax circuit. Dr. Tejasvi, modification of Mapleson A, lax.
Okay.
Modification of
So
A.
it's a modification of A, that is lax circuit. It is a coaxial modification of Mapleson A circuit. The port in Mapleson A, we had a APL wall over here at the patient end. So there was disadvantage of Mapleson A, that this wall being at the patient end, we were unable to approach it and also unable to scavenge the gases. So this modification takes out those disadvantages. That is, it is easy access of expiratory wall and easy scavenging of the expired gas, but it increases the work of breathing. Okay. So for testing all this system, we have to test for Mapleson A basically and lax both. We have to check for the integrated leak, that we have to pressurize the system, and we have to check for the leaks, if any. Okay, if there is any leak, we can just know that. After that, we have to check for APL wall. We have to tighten the APL wall. We have to check for is there any, if we are able to pressurize the system with a closed APL wall. We have to open the APL wall and look that are we able to vent out the gases through the APL wall. Okay, so these two tests we have to do for each and every system. For checking the integrity of the inner tubing in lax system, we can do it by two methods. We can either attach a tracheal tube to an inner tube of the patient end of the circuit, and we have to close the APL wall. Okay, so if we close the APL wall over here, and if we attach the endotracheal tube to the inner tube, and if we try and blow out, we will not be able to blow out as APL wall is closed. But this reservoir bag will also be deflated if integrity of APL wall is correct. But if there is any leak, we will be able to blow out, and those gas will be filled in reservoir bag. So that is the way of checking the integrity of inner tube. Another way of checking this coaxial lax circuit is we have to occlude both the limbs, that is inner tube and outer tube, and we have to pressurize the system. Okay, and after the adequate pressure has been attained, we have to try and squeeze the bag with APL wall open. If the inner tube integrity is there, we will be not able to squeeze the bag. But if there is leakage in the inner tube, then at that point we will be able to squeeze out, because of the leakage, the pressure inside in the expiratory limb will be vented out through the APL wall. Okay, so these are the pre-use checks for lax circuit. Coming to Mapleson B and C systems. So these are not routinely used. These are not that famous. Mainly, points to remember is for both this system, we have to use at least 2 to 3 times the minute ventilation as a fresh gas flow. Mapleson C circuit, that is water circuit, is used for resuscitation purpose. And if we are adding a water canister, that is CO2 absorber, then it becomes water to and fro system with CO2 absorber. Okay. Coming to next, Mapleson D system. This is most extensively used and also said to be a universal circuit. It is described to be a T-piece. If we look at this circuit, the proximal part is a T-piece, and it has a fresh gas entry point at the patient end. Okay, so the fresh gas inlet is located near the patient end, and the expiratory valve is present at the near the back. Okay, near the reservoir back. This is the arrangement. So Baines had modified this circuit, Mapleson-D circuit, into a coaxial circuit in 1972, in which the fresh gas flow which was near the patient end is kept to be near patient end, but it is coaxially arranged, and the entry point of fresh gas flow is at the back end, but the opening is at the patient end. So functionally it is same. So if we go into specification of Baines circuit, it is 1.8 meters with an internal diameter of the outer corrugated tubing to be 22 millimeters and internal diameter of the inner tubing to be 7 millimeters. Okay. So we have seen that 1 meter of the corrugated tubing of 22 mm will accommodate a volume of around 450 to 500 ml. But we have kept this to be 1.8 meters. This tube also will accommodate a tidal volume of around 500 ml, because the 7 mm of it tube will be having some of the volume. That okay. So these are the specification, and expiratory valve is also called as APL valve during controlled ventilation is placed near the reservoir bag. So coming to functional analysis of Baines circuit, similar principle applies over here, that during spontaneous ventilation, we will be keeping the APL valve open. During controlled ventilation, we will be keeping the APL valve partially closed. Second point, that during spontaneous ventilation, the APL valve will open during expiratory phase, where the pressure inside the circuit will increase. Okay, and during controlled ventilation, venting out of the gas will occur during inspiration, where there will be increase in the circuit pressure during inspiratory time. So coming to Baines circuit functional analysis during spontaneous ventilation, during late part of the inspiration, we will have a good amount of fresh gas going to the patient. Okay, during early phase of expiration, we are having a fresh gas entry at this point, that is at the patient end of the circuit. Okay, so during early phase of expiration, there will be a mixture of inspired and expired gas coming in this corrugated tube. Okay, during expirative pause phase, where there is no fresh alveolar gas coming to the circuit, but fresh gas flow will continue. This will push the expired gas towards the APL valve, and most of the dead space and expired gas will be vented out during spontaneous ventilation, provided there is adequate fresh gas flow. Okay, so during expiration, adequate fresh gas flow is very important. Also, second important point to decrease the rebreathing is to have good expiratory pause phase. So if we are having a good longer expiratory pause phase or higher inspiratory is to expiratory ratio, then there will be minimal rebreathing. But taking into consideration the patient's condition, his anxiety, most of the patients will have shallow breathing and rapid breathing. So this circuit is not that good as compared to Mapleson-A for spontaneous breathing. Okay, so in next inspiratory phase, the most of the fresh gas and some of the alveolar gas will be delivered to the patient. So this is about spontaneous ventilation. So Baines circuit for controlled ventilation, it is considered to be very good for controlled ventilation. Okay, so if we go into functional analysis, as already discussed, APL valve will open during inspiratory phase. Okay, so during inspiratory phase, at the late inspiratory phase, patient will get good amount of fresh gas flow. During expiratory phase, as there will be no venting out of the gas during expiratory phase, there will be a mixture of fresh gas and alveolar gas will get accumulated in the circuit. Okay, and during during the inspiration phase, most of the gas towards the fresh gas flow point will be vented out, and some part of alveolar and dead space gas will be rebreathed. There will be minimal rebreathing if there is good amount of fresh gas flow. Okay, for that, as we know that if we prolong the expiratory phase over here, there will be this alveolar gas will be pushed towards the bag and APL wall during expiratory. So during control ventilation, the expiratory phase, we are having that control. And whenever we are using Baines circuit, we have to prolong the expiratory phase. We have to keep inspiratory phase short, and expiratory phase, that is expiratory pause phase, should be longer. Then there will be minimal rebreathing using Baines circuit. Okay, so with that, we can minimize very minimal of alveolar gases can be delivered to the patient. So this is very good for controlled ventilation. So advantages of Baines circuit is it is universal circuit. It can be used for most of the age groups. It is best Mapleson for controlled ventilation. It is lightweight and coaxial arrangement makes it convenient to use. Long length of the circuit makes it easy to be placed away from the patient and also useful during MRI. So for MRI, we can have a circuit with a length of around 540 centimeters. Okay. And also for head and neck surgeries and all those patients, we can also have a circuit with a longer limb. So if we are increasing the length of the circuit, the functional analysis will not change. Okay. So we can increase the length of this circuit to whatever desired we like. So it is disposable and easily sterilized and reusable. Warming and humidification of inspired gases can occur during this use of Baines circuit. The disadvantage is that being a coaxialing nature, if there is a kinking of the inner tubing, or if there is any leakage in the inner tubing, whole of the corrugated tube will act as a dead space, and it can cause hypoxia and hypercapnia. So to Baines circuit, coming to the Baines circuit testing for the circuit. As already discussed, we have to check for the pre-use checks we have to do. Okay, in that we have to just pressurize the system and check for if there is any leak. It is recommended that if circuit is new or if it is we have to attach the circuit and we have to try and breathe in and breathe out of the circuit. Okay, after checking for the leaks, we can also try and breathe in and breathe out of this circuit. Other thing is we have to check for the integrity of the tube. It can be done by two tests. That is one of the, it is Patency test. It is very famous test which uses Venturi principle. Okay. In this test, we have to occlude the outer tubing and outer tubing, that is at patient end of the circuit, and we have to fill the reservoir bag. We can fill the reservoir bag with either using flush, or we can put on the flow meter to 3 to 4 liters. When the reservoir bag is completely full, we have to remove the occlusion and we have to flush the circuit. We have to push the flush button simultaneously. This has to be done simultaneously. Okay. So if we are just removing the patient end of the circuit, and if you are not pressing the flush button, there are chances that the reservoir bag will collapse. So it has to be done simultaneously. And if the inner tube is intact, the bag will deflate by Venturi effect because of high flow, nearly 30 to 40 liters of the liter per minute of the flow. There will be negative pressure generated around the inner tubing, which will suck in the gas in corrugated tubing, and which will cause deflation of the bag if inner tubing is intact. But if inner tubing is not intact, or if there is a leak in inner tubing, then in that case, the bag will not deflate because it will create a high pressure in the corrugated tubing also. So this is the test to see for the patency of the inner tubing, that is Patency test. Okay, so if inner tubing is intact, it will cause deflation of the bag. If inner tubing is not intact, the bag will not be deflated. It will remain inflated. Okay. Next test is Fox-Crompton-Smith test. In this test, we put the flow meter on to 3 to 4 liters of oxygen. Now we occlude the inner tube at the patient end, and we observe the flow meter bobbing. Okay, so whenever we will be occluding the inner tube, the flow meter bobbin should dip. If it dips, then the inner tubing is patent. So these are the two test favorite questions for Viva of most of the examiners. So every student should know. Coming to next circuit, that is next is ISTPs. It was introduced by Phillips in 1937. Originally, it was metallic. It was 5 centimeters in length and 1 centimeter in diameter. So this ISTPs is not routinely used nowadays, and to use it, we have to keep at least 2 to 3 times the fresh gas flow. Advantages of it was it had low dead space. There was no walls and no resistance. If we are using it for spontaneous breathing, we have to keep the expiratory port open. If we are using ISTPs and if we want to give controlled ventilation, we have to intermittently occlude the patient expiratory port to give inspirations. Okay. So Mapleson E is a modification of ISTPs wherein a corrugated tubing, this corrugated tubing has been added to the TPs. This is the same TPs, that is a fresh gas flow, patient end, and expiratory port. Okay. So the corrugated tubing has been added to the expiratory port. This system is also not routinely used, but it is used in ICU patients for whom extubation is been pending in spontaneously breathing patients. Okay. So there is a modification of Mapleson E has been modified, and a bag has been added to this corrugated tube. This was done by Jackson and Rees and is called as Jackson and Rees circuit. Okay. So a further modification of this Jackson and Rees circuit is that a valve has been added. Okay, which is routinely used nowadays. So original Jackson and Rees circuit didn't have a valve over here. It was an open port. Okay. So this circuit can accommodate a tidal volume of around 150 ml. So it can be used for a patient, children under 20 kgs of weight. So these systems, that is Mapleson D, E, F, are all functionally similar for spontaneous and controlled ventilation. Okay. So as we know that Mapleson D system is very good for controlled ventilation. Similarly, Mapleson F also, that is Jackson and Rees, is very good for controlled ventilation. So in case of spontaneous breathing, we have to keep the tidal volume for at least 2 to 3 times the minute ventilation. Okay. And there is a at minimum tidal volume of 3 liters should be maintained irrespective of weight whenever we are using Jackson and Rees in case of spontaneous ventilation. Advantage of Mapleson F, that is Jackson and Rees, it is simple, easy to assemble, it is lightweight, it has a minimal dead space and resistance, it is portable, there are no walls, it is equally effective for both controlled and spontaneous ventilation. Disadvantage is that there is high fresh gas flow is required, humidification, it lacks humidification, and occlusion of the wall, if wall is there, or occlusion of the port will cause a high risk of barotrauma. So these are the questions for all the participants.
So the first
You can.
question, yeah, can I read it for you, sir?
Yeah.
So the first question is, which is the circuit of choice for spontaneous respiration? You can please type your answers in the chat box. So few answers are coming, sir. Most of them are saying Mapleson A. And one
Okay.
of them has said Baines.
No, it's answer is Mapleson A circuit. Okay.
And the next question is,
Magill's.
which is the circuit?
That is Magill's circuit. Yeah. Not Baines. The Baines is not a right answer. It's Magill circuit or Mapleson A. Okay.
So Mapleson A is a circuit of choice for spontaneous respiration. So moving on to the next question, which is the circuit of choice for controlled ventilation? Please type your answers.
You can type answer that 1A, and 2. Just you can write the number of question number before the answer.
Yeah, so
2 Baines. Okay.
Baines and Mapleson D.
Okay. And
So the third question is, which is the circuit of choice for pediatric age group? So question number 3 is Jackson Reese, Mapleson F.
Okay. So we can move forward. So to summarize, Mapleson A circuit Magill's is very good. It's very good for spontaneous respiration. Okay. Mapleson B and C systems are hardly used. Mapleson D system is very good for controlled ventilation. So Mapleson A for spontaneous ventilation around 1 minute ventilation, and Mapleson D for controlled ventilation around 1 to 2 minute ventilation. Rest all breathing circuits 2 to 3 times the minute ventilation is to be kept to avoid rebreathing. Okay. To just summarize. So next comes non-rebreathing system. There are many non-rebreathing valves like Rubin valve, Stephen Slater valve, Ambu valve. Okay, these are the valves with three. These are having a patient end, inspiratory end, and expiratory end. So during inspiration, the spring-loaded valve, the expiratory port gets closed, so patient can inspire through this circuit. And during expiratory phase, the inspiratory port is closed and patient can expire through the expiratory port. So some old examiners may ask a question that Magill's Mapleson A, that is Magill circuit is good for spontaneous ventilation. So how can we use Magill circuit for controlled ventilation? You can just answer that we can replace this APL valve with non-rebreathing valve, and we can use Magill circuit as effectively for controlled ventilation as for spontaneous. Okay, so this is just a pros and cons we can just answer, but it's hardly used nowadays. Other non-rebreathing systems are Ambu bag. It's routinely used for resuscitation purpose. Okay, so it's simple, portable, and we can deliver 100% of the oxygen. At this port, at the patient end, the expired gases will be vented out. Okay. So it has a one-way valve. There is no rebreathing. Coming to closed system will be dealt in detail in next chapter. Closed circle and circle system and low gas anesthesia. But to just complete the breathing systems, I will just go through the closed system also. So the components of closed circle system are corrugated tubing for inspiratory limb, expiratory limb, unidirectional valves, CO2 absorber, fresh gas flow, and APL valve with reservoir. Mainly the ideal arrangement of closed components of this system are, there are multiple possible arrangements for the reservoir bag, unidirectional valve, inspiratory port, all those things. So unidirectional valve should be as close to the patient as possible. fresh gas flow should be downstream to the soda line. It should be between soda line and inspiratory port. Okay, it should not be beyond the inspiratory port. That is, it should not be downstream the inspiratory port, because during expiration there will be wastage of fresh gas flow. Okay, during expiration, this fresh gas will go in expiratory limb. So it should not be below the inspiratory unidirectional valve. APL valve, it should be APL valve and reservoir bag should be between expiratory unidirectional valve and absorber. Okay, functional analysis has the same concepts we will be using, that where if it is on bag mode, if it is on ventilator mode, the part will be taken care by ventilator. But if whenever it is on bag mode and it is spontaneous or control breaths, depending on the which, if it is a spontaneous breaths, we will be keeping the APL valve open. If it is control breaths, APL valve will be partially closed. In spontaneous breaths, a venting out of the gas will occur during expiratory phase. In control breaths, venting out of the gas will occur during inspiratory phase. Okay, so during inspiratory phase, as we keep a low gas during in the circle system, this fresh gas flow which is available will not be able to, patient will not be able to attain his peak inspiratory flow rate. So the gas in the bag will be sucked in the inspiratory limb, but it has to pass through CO2 absorber. So the expired gas without CO2 will be reused in this closed circuit. Okay, this is in inspiratory phase. During early part of expiratory phase, the fresh gas flow, the inspiratory valve will close, and the fresh gas flow will continue to pass through the expiratory limb on through the inspiratory limb, and expiratory gas will also pass. All these gases will move towards the reservoir bag. During the expiratory pause time, if it is in spontaneous breath, there will be venting out of the gas through APL valve. Okay, so this is the functional analysis of closed circuit. Advantage: it is economically better, preservation of heat and humidity occurs. CO2 tension will not depend on fresh gas flow, as seen in open circuits, where if we keep low fresh gas flow, there will be risk of rebreathing and CO2 will increase. But in closed circuits, there is no risk of rebreathing or minimal risk. So over here, arterial CO2 tension will depend on minute ventilation and not on fresh gas flow. There is low dead space. In case of this system, the part beyond the Y-piece is a dead space. Okay, so there is less dead space and there is less of atmospheric pollution. Disadvantage is many components are there, so there are chances of disconnection, misconnection. Okay, and those complications on all those will be dealt. So components of breathings, these components are common for all the systems. APL valve, unidirectional valve are basically for closed circle system. So functioning of unidirectional valve is that these are a disc-shaped valve, disc-shaped flap valve placed on a tubing. Okay, so the tubing on which it is placed will determine which valve it is. That is, if we are using it as an inspiratory valve, so the inner tubing will be the fresh, the inspiratory tubing. Okay, that is the tubing from the, that is, it will be apparent tubing from machine towards the patient. So during inspiration, there will be negative pressure in the outer tubing and positive pressure in the inner tube, which will cause opening up of this valve. Okay, and during expiration, there will be the positive pressure in the patient outer tubing, and which will cause closing of this inspiratory valve, and vice versa is true for expiratory valve. Okay, so expiratory valve, there is a risk of malfunctioning because of humidification. Okay, so APL valve, there are various types of APL valve. It may be variable orifice or pressure regulated type of APL valves. Okay, as already discussed multiple times, in spontaneous breathing, we will be keeping APL valve open. Okay, so there will be spontaneous venting out of the expired gases. During controlled ventilation, we will be putting this APL valve in a partially closed. When the pressure inside the circuit reaches that pressure, then and then there will be venting out of the gases. So CO2 absorber, all these things will be taken care of in next lecture also. There are, if it is single canister, 700 to 900, double canister 1.8 grams. These are the absorbers, soda lime, berylime. Okay, and mainly soda lime and berylime are used. So hardness, these are made hard by adding silica, and the size of granules is 4 to 8 mesh. Mesh size is the number of holes in a 1 square inch of the plate. Okay, so larger the number, smaller are the granules. So this reaction, carbon dioxide will react with water and generate carbonic acid, which will react with sodium hydroxide to generate sodium carbonate, which will react with calcium carbonate to form calcium carbonate. Okay, calcium hydroxide to form calcium carbonate, and sodium hydroxide will be regenerated. So the indicators, various indicators are used. We just need to know which indicator is being used in our circuit. Okay, because it is important, because if it is white color, it may be a fresh or an exhausted soda lime if Mimosa Z is used. Okay. So these complications, the complications are the compound A, halogens, and carbon monoxide. All these things will be done. So coming to reservoir bag, which is common for all the circuits, not necessarily for closed circuits. Okay. So this reservoir bag is placed at the between expiratory valve and canister in case of closed circuit. But in case of open circuits, position of the bag depends on the type of circuit. So main function of reservoir bag, it serves as a reservoir for exhaled gases and excess of fresh gas, and it helps to attain the peak inspiratory flow rate. So this main function may be asked to you. So we'll just take an example of a 70 to 80 kg of patient with a tidal volume of nearly 500 ml, and if we are giving a breath rate of 20, so we will be having his for every 3 seconds we will have one single breath. Okay, so if we are keeping inspiratory to expiratory ratio is 1:2, so he will be breathing this 500 ml of tidal volume in a second. If attending this 500 ml of tidal volume in a second will not be possible, will require a high fresh gas flow as high as 30 liters. So this is not at all economical. Okay, for that purpose, that purpose during inspiration, that peak inspiratory flow rate will be attained with the use of reservoir bag. Okay, so reservoir bag has various capacities. Okay, it comes from 0.5 liters to 3 liters. Okay, so according to the weight of the this reservoir bag can be selected. Ideally, nearly 30 to 35 ml per kg of the calculated volume should be ideal volume of a reservoir bag. So other functions are, it can deliver manual ventilation, or it can assist during assisted spontaneous breaths. It has a visual and tactile means of monitoring a patient's spontaneous breaths. It also partially protects the excessive potassium pressure in the breathing system. So last point, how it prevents is that a standard adult breathing bag has a nominal value of 3 liters. Okay, and pediatric bag has a value of 5 liters. According to American Society for Testing and Material, ideally, if we inflate this reservoir bag to 4 times the volume, it should attain a pressure of at least 30 centimeters of water, and pressure should not exceed more than 60 centimeters of water. They have given it as if it is less than 1.5 liters of the bag, 30 and 50. That is, it should be at least 30 and not more than 50. And if the bag is of more than 1.5 liters, the pressure should be at least 35 and not more than 60. Okay, so you can just remember that approximately at least 30 centimeters of the pressure should be attained and not more than 60 centimeters of water of pressure should be attained. So the reservoir bag fills in these three phases. In first phase, there will be no increase in pressure. The capacity of reservoir bag will get filled. If we inflate it to at least four times the capacity, there will be a sharp increase in the pressure. That is phase 2. And in phase 3, there will be no further increase in the pressure. Over here, Laplace law will be applicable. So coming to a question to all participants, who can identify this circuit?
Please type your answer in the chat box. You have to identify this circuit. Please type the name of the circuit.
So I can give a hint that there is no APL wall over here. No APL wall available over here.
The answers are coming in. Dr. Praveen, Dr. Sonal, they're saying lax circuit. Dr. Spurti is saying
I'm giving a hint that there is no APL wall over here. Okay. This is a coaxial circuit.
Dr. Prakash is saying Mapleson E or F.
So I have not covered this, but it is just to test your knowledge. This is not JR lax circuit. This is not McGill circuit. This is not Bain circuit. This is a circle system coaxially arranged. Okay. So this is the expiratory port and this is the inspiratory port. Okay. So there are this is coaxially arranged two tubes and it will open over here. So this point is similar to the Y point, Y piece in closed circuit. Okay. So this is universal F circuit or universal single limb breathing circuit. Okay. So if there is if instead of these tubes, if there is a septum separating the inspiratory and expiratory limb, it will be called as limb O circuit. Okay. So it is universal F circuit, or you can also call it as a universal single limb breathing circuit or limb O circuit. Okay. So to check pre-use checking the circle system also, we can test universal negative test for machine leak. In this, we can just check where we can most of the workstations have inbuilt leak testing. Okay. So, but if we want to manually check for the leak, we can just inflate, attach a deflated balloon to the fresh gas entry point and leave it. If there is minor leak, this balloon will be re-inflated. Okay. If there is a leak in flow meter assembly, or if there is a leak in vaporizers also. To check for leak in vaporizers, we have to put on the vaporizer. Okay. So this is the leak testing. Second is leak testing for the circuit. For the circuit, we have to close the circuit endpoint, or we have to attach a bag, and we have to increase the circuit pressure to 30 centimeters of water, and we have to close all the flows, and wait for and observe the pressure. If this 30 centimeters of pressure is maintained for at least 10 seconds, then there is minimal or no leak. But if there is a leak and if there is a fall in pressure, we have to increase we have to put on the flow meter, and the flow meter at which there is the 30 centimeters of water pressure is maintained, that much amount of leak is present. Okay. So this is standard test. Other test is for functioning of the APL valve, which we have seen for Bain circuit. Similar testing we can do. And functioning of the unidirectional valve. Unidirectional valve, it can be tested in two ways, either breathing or applying the negative pressure. In breathing, just if we look at this, whenever we are testing for inspiratory unidirectional valve, we have to disconnect the circuit over here. We have to close the expiratory port with our hand, and we have to try and breathe through this circuit, through the inspiratory port. If you are able to inspire through this inspiratory port, then the unidirectional valve is functioning during inspiration. But we should not be able to expire. Okay, if the unidirectional valve is functioning properly, because we have closed this port. Okay, so we will not be able to expire during the expiratory phase, and we will be able to inspire during the inspiratory phase if this valve is functioning properly. Similarly, we can test for expiratory unidirectional valve also. Okay. Other way is you can just apply a negative pressure balloon on the inspiratory port and or expiratory port and test the functionality of the valve. So part of breathing circuits, part of the breathing circuit has we have covered most of the points. Okay, so if we are having any doubts, we'll take it at the end. Coming to second part of the today's discussion, gas laws. I'll try and cover all these laws, okay, in brief, basically. So first law is Boyle's law. It states that at constant temperature, volume of the given mass of gas is inversely proportional to the absolute pressure. Okay, so if the pressure increases, the volume will decrease and vice versa. Okay, so this same law is utilized for oxygen cylinder, creating oxygen cylinder wherein a pressurized gas, high volume of pressurized gas is stored in oxygen cylinders. Okay, so this can be rewritten as PV is constant, that is pressure into volume is constant if temperature is kept constant. So if we take the example of this oxygen cylinder itself, so we can calculate how much of the oxygen is present in a full cylinder, whatever cylinder we take. So we'll take an example of E type of cylinder for our today's discussion. As you know, E type of cylinder has a inner capacity of 5 liters. Okay, so it has a 5 liter capacity. The pressure at which the oxygen has been filled in these cylinders is around varies from 1900 to 2200. So if we take pressure around 2000 psi, and if we consider if we want to calculate the oxygen it can deliver at 15 psi. 15 psi is near 14.7 psi is 1 atmospheric pressure. Okay, that is how much of the oxygen will be available at the atmospheric pressure in a full E type of cylinder. We can just put it in this equation, that is PV is constant, that is PV P1 V1 is equal to P2 V2, and we can get that in a full E type of cylinder we have a 665 liters of oxygen. Okay, and we have a 660 liters of around 660 liters of deliverable oxygen. This 5 liters will be returned back in the cylinder. Cylinder itself has a 5 liters of capacity. Okay, another example is if we consider a patient of pneumothorax. If any patient at a sea level gets injury and he has a pneumothorax and he needs to be airlifted. So if we airlift this patient, there is a chance that there will be decrease in atmospheric pressure. Okay, so if the pneumothorax volume is X volume or something, for example, 200 ml of volume is there of pneumothorax. So if we airlift the patient, there is chance that this volume of pneumothorax will increase, and it can even cause to it can lead to tension pneumothorax also. So this thing one has to keep in mind. Over here, Boyle's law is applicable. That is pressure in volume is equal. Similar other example are also there, that we inflate the cuff with during hyperbaric therapy. We inflate the cuff with saline and not with air. Okay, so I think Boyle's law has been, everyone got the Boyle's law. Okay, so second is Charles' law, which states that at a constant pressure, there is a direct relation of pressure, temperature, and volume. So these three laws, one thing has been kept constant. In Boyle's law, we have kept the temperature constant, and the relation of volume and pressure was discussed. In Charles' law, pressure is being kept constant, and so in this case, volume of gas is directly proportional to temperature. Okay, so if there is increase in temperature, there will be increase in volume of the gas. Okay, so main example, physiological example is that if we inspire a particular volume, for say for example, for 500 ml of tidal volume, it reaches the alveolar level. If we have inspired 5 ml of volume, and the volume which has reached at alveolar level is 500, but because of body temperature, this will expand, and available volume of gas for air exchange will be around 530 ml. Okay, so there is a direct relation of volume with temperatures. Increase in temperature will cause increase in volume. So third law is Gay-Lussac's law, which states that at constant pressure, at constant volume, pressure is directly proportional to temperature. So if we keep the volume constant, increasing the temperature will increase the pressure of the gas. Okay, so P is directly proportional to T. So this is the reason why these cylinders, all the cylinders, are not kept at the site where there is a risk of increasing temperature, because it will cause increase in the pressure inside the cylinder, and those cylinders are at a risk of explosion. So there are multiple safety mechanisms also to avoid explosion. So putting all these three laws together, we get an universal gas constant. Okay, that is pressure into volume is equal to N, that is number of mole, into R, that is universal gas constant, and temperature. Okay, but this is applicable for gases. Okay, so if we consider as a cylinder, oxygen cylinder, we are discussing of oxygen cylinder only right now. Okay, so if we consider in an oxygen cylinder, we can consider that volume of gas is constant. That is, E type of cylinder will have 5 liters of volume. R is a universal gas constant. Temperature, that is OT temperature, is kept constant. So in that case, pressure will be directly proportional to number of moles, that is gas. So over here, the Bourdon gauge will act as a, will show, that is pressure will show how much the number of molecules of gas is there. As we saw that there is a, in a complete full E type of cylinder with 200 psi of pressure, it contains 660 liters of oxygen. So if the psi reading on the gauge shows 1000 psi, then we can say that nearly 50% of the oxygen has been utilized. Okay, and this, the cylinder is half filled, that is nearly 330 liters of oxygen is available. Okay, so this we can just get it from universal gas constant law. Coming to next, so this law is not applicable. Universal gas law is not applicable for nitrous oxide, as in nitrous oxide the critical temperature is 37 degrees Celsius. So below 37 degrees Celsius, if the nitrous oxide is filled in under a pressurized chamber, it will be in a liquid state. Okay, so whenever the gas will come out, the liquid will get converted into gases, and we can't, that 750 of psi will be maintained throughout the nitrous oxide usage till all the liquid has been exhausted and complete nitrous oxide cylinder is filled with gas. When all the nitrous oxide cylinder is completely exhausted of liquid, and when it is only filled with gas, at that point of time, we can use this universal gas laws, and we can just say that whatever the pressure is on gauze, Bourdon's gauze, that is that much amount of the gas is there in nitrous oxide. Okay, so for nitrous oxide, we have to use this Avogadro's hypothesis. which states that at a equal volume of gas, state the equal volume of gas contains equal number of molecules at standard temperature and pressure. So what is the standard temperature and pressure over here? The standard temperature and pressure is 273 kelvins and pressure is 760. Okay, that is 1 atmospheric pressure. So at that case, one mole contains 6.23 into 10 raised to 23 of molecules, that is 22.4 liters of volume. When this one mole is expressed in weight, that is in gram, it is said to be gram molecular weight. Okay. So to calculate how much of the nitrous oxide is present in E type of cylinder, we have to consider that this E type of cylinder has a weight of 5 kg. Okay. Liquid nitrogen, if we fill this complete cylinder with water, it will accumulate nearly 5 kg of water. But nitrous oxide being heavy, it will have only 3.3 kg of, we will be able to accommodate only 3.3 kgs of nitrous in a full type of E type of cylinder. Okay. So this we can just get it weighing the nitrous oxide cylinder also. What is the weight of the nitrous oxide cylinder? So the gram molecular weight of nitrous oxide is 44. So 44 grams of nitrous oxide will give 22.4 liters of nitrous oxide at room pressure. Okay. So 3.3 kg, that is 3,300 grams of nitrous oxide will give us 1,680 liters of nitrous oxide. This is at standard temperature and pressure, that is 0 degrees Celsius. If we derive it at 20 degrees Celsius, that is if we add 20 degrees Celsius to 273 kelvins, we will get it as a 1,800 liters of nitrous oxide in a full type of E type of nitrous oxide. Okay. So this is the way how much nitrous oxide is remaining in the cylinder. This is the way to calculate using Avogadro's hypothesis. Okay. So coming to the favorite topic for Viva is Bernoulli principle. It states that when a gas flowing through a tube encounters a constriction, at that point the pressure drops and the velocity increases. That is, the kinetic energy will increase and potential energy, that is pressure, will decrease. This is called as Bernoulli principle. So this principle is utilized in medical equipments, and the effect where we utilize it is known as Venturi effect, where we use the fall in pressure over here, we use to entrap the surrounding air or surrounding fluids. Okay. So uses of Venturi effect are during use of oxygen therapy, Venturi mask. Whenever there is a normal tube is there, whenever there is a constriction, the flow velocity will increase, but the pressure at this point will decrease, which will cause entrapment of the air from the surrounding. Okay. So this is used for Venturi mask, oxygen therapy, also jet ventilation, nebulization chamber, also in modern vaporizers for checking the patency of Bell circuit, also in Drager machine to reduce the pressure of the gases. Bernoulli principle is also used in echocardiography to derive the pressure. Derive the pressure. Okay, that is difference of pressure between the walls. Also, we can use this principle also. This principle again. Coming to Hagen-Poiseuille's law, it is applicable for laminar flow, any flow, all the flow, flow of gases, flow of fluids. This law will be applicable. This law states that the flow will be dependent on the 4th the power of radius, difference of the pressure, and inversely proportional to the length of the tubing. Okay, so if you want to increase the flow, either we have to increase the radius. Okay, that is we have to put the wide bore cannula, or we have to increase the diameter of the tubing. Okay, to decrease the resistance, we can also increase the diameter of tubing. So it is recommended to put a larger, adequate, the maximum possible size of endotracheal tube also, so that there is good flow and less of resistance. Okay, so this is depending on the radius of the tubes. Or there can be difference in pressure, like for TURP, we can increase the height. Increasing the height also will increase the pressure and flow will increase. Okay, or we can decrease the length of the tubing. Decreasing the length of the tubing will also increase the flow of the tube. Okay, so this is about Hagen-Poisson's law. Coming to Reynolds number, it is a unitless number which depends on velocity, linear dimensions, density, and viscosity. So linear dimensions, if there is any acute curves or bends, it will increase the Reynolds number. And if Reynolds number is more than 2000, there will be turbulent flow. And if Reynolds number is less than 2000, the flow will be preferably laminar flow. Okay. So whenever there is sharp bends, it will cause turbulence to the flow. Okay. So whichever connectors and circuits we are using for anywhere, they should be wide bore and curved rather than sharp angle. Okay. So pointing effect. This is also a Viva question for most of the time. So we have seen that critical temperature of nitrous oxide is 37 degrees Celsius. So below 37, above 37 degrees Celsius, whatever pressure we apply, we will not able to liquefy nitrous oxide. Okay. Similarly, the critical temperature for oxygen is minus 118 degrees Celsius. So to store oxygen in a liquid state, we have to decrease the temperature to less than 118 minus 118 degrees Celsius. Okay. So, but if two gases with different critical temperature are mixed, the critical temperature of the gas with a higher critical temperature will decrease to lower one. Okay, will be between. It will not be 118, but it will decrease. So in case of Antonox, the critical temperature of nitrous oxide will decrease from 37 degrees Celsius to minus 6 degrees Celsius. So normally nitrous oxide cylinders are on room temperature, are in liquid state under a pressurized. But whenever a proper pressure is maintained, it is in a liquid state. But Antonox cylinder will be in a gaseous state. That is O2 and nitrous both will be in a gaseous state above 6 degrees of Celsius. But in case of cold climates, if we are using Antonox cylinder and early morning if you are using, and if the temperature is less than 6 degrees Celsius, there are chances that nitrous oxide will liquefy and this cylinder will have preferentially only oxygen, and early part of the use only oxygen will be delivered and the effect of nitrous oxide will not be visible in the patient. Okay. And later part. So later part of the use, only nitrous oxide will be delivered, which can cause hypoxia. So to prevent it, we have to note the room temperature, and we can just before using, we have to increase the temperature and use, shake properly, shake thoroughly, and then use. Okay. So these are my reference, and I think we can discuss if there are any queries. And thank you.
Thank you so much, sir. It was an exhaustive topic, and thank you for this clarity on this topic. So we have few questions with us, and in the meantime, I'll request Madhuri ma'am to say a few words about the gas laws and our circuits.
Thank you, Dr. Monica. How much time do we have? 15 minutes, right, for discussion?
Yeah.
Okay. So I really congratulate Dr. Tushar for having accepted to talk on this very, it's not a very simple topic, this breathing systems and gas laws. And time and again, we have seen during postgraduate exams, students come and they are just unable to answer. What we do is we ask them to pick up a circuit. As soon as the student comes to the table viva usually takes place after the long and short case. So they will be quite tired. And when they come for the table viva voice, the favorite question of the examiner will be, pick up any circuit of your choice and start speaking on it. So I would advise all the students to keep one circuit ready always. You should not pit-pat about it. That doesn't mean that you should not know the other circuits. You should know all, but about this, you should know each and everything. Because when you pick up a circuit of your choice, you should know every question that is asked on that, you should be able to answer. Okay. So now, once you pick up the circuit, next, what are you going to say? So most of the times we see that students start talking haphazardly, Suddenly he will tell it's like we'll ask, okay, what type of circuit it is? Okay, then he will tell it is Mapleson A, B, C, D, whatever. Then after that, immediately they will jump on to the advantages of the circuit, okay, then to the hazards or something like that. So my advice to all the students here would be that you have to tell in a systematic way so that you can direct your examiner to ask you questions which you know to answer. So when you pick up the circuit, you have to tell the name of the circuit and how it comes in which category as per the classification. Now, as far as classification is concerned, our speaker has already told that there are so many methods of classification of the breathing systems. And let me tell you that there is a variation in the interpretation of the classification of these breathing systems. There are so many classifications. But the most commonly used classification is the Mapleson system. And that is what Sir has covered today. So what is the speciality of Mapleson systems? Mapleson systems, they are also known as CO2 washout circuits. And they depend on fresh gas flow totally for the elimination of CO2. And there is no other provision for the removal of CO2 in these circuits. So this is the characteristic of Mapleson circuits. You can call them as CO2 washout circuits. Okay. Now, once you tell the category of the circuit, next you have to tell the parts of the circuit. Don't wait for the examiner to ask you, now tell me what is in your hand, which part is this. So go on telling the parts of the circuit, like Sir has already told you, the patient end, the machine end, the corrugated tubing, the APL valve or whichever valve, and all those parts, you go on telling. Then comes the parts and the components. Then many a times the examiner will dismantle the entire circuit and give you. He'll just dismantle the APL valve over here, the head brake valve in one place, the corrugated tubing in one place, and everything will be dismantled and you will be asked to assemble everything together. And this is where you start fumbling. So if you know the parts properly and if you know the functional analysis of the circuit properly, at the Viva table, you will be very confident and you will know how to assemble the parts together. You will not do ulta palta arrangement over there. Then after that, you have to tell what are the merits of that circuit, what are the advantages of the circuit, and what are the disadvantages of the circuit. Then, of course, the functional analysis that is already told to you. And then you should know the resistance and the compliance of the each circuit pit-pat. We should know it pit-pat. And I think you better make a chart and write down what is the resistance of Bain circuit, what is the resistance of TPs, what is the resistance of Magill circuit, and so on. And resistance, when you tell, you should tell at what flow rate. Many of you all tell the resistance. Yeah, the resistance is 0.5 centimeters of water. But at what flow rate? That is very important, because any resistance told without telling the flow rate doesn't carry any meaning. Then comes the next question that is going to be asked to you is, tell me how you're going to test this circuit. So you should know how to test the circuit. And I think Sir has told you all Patency Test, and there are so many other tests which you should know. Practically, you will be asked, you show me how to test this circuit. And most of the students start fumbling with Patency Test itself. Then comes the various modifications of the circuit. I think that is again a very, it's again, if you go into the depths of each circuit, you will know. Okay, there are various modifications of the McGill circuit. There are various modifications of the TPs, which many of the students do not know. So, what are the modifications of the McGill circuit? Can anybody tell me? You can put it in the chat box. Any modifications of McGill circuit? Can anybody tell me? No answer.
Please type in the chat box the
Please type in the type box, in the chat box.
So the answers are coming in, ma'am.
Yeah.
It's LAC circuit by Dr. Sharmila.
No, LAX is a modification of Mapleson A. I want a modification of the McGill circuit. So there are various modifications, like, you can McGill's has got a head brink valve. So if you replace the head brink valve with a Rubens valve, which sir was showing just now, or maybe with an Ambu E valve, then what happens? This prevents rebreathing, and maybe you can use it with controlled ventilation. But of course, this is with a word of caution because it is the best circuit for spontaneous ventilation. Then there are many other modifications like Sykes modification, or you can even insert a safety pin through the two vent holes of the head brink valve. If you do that, the valve becomes inefficient. Then there are several modifications of the TPs. Can anybody tell me the modifications of TPs if you are asked? I'll send you a chocolate if you can tell me. Modifications of the TPs.
So please type your answers in the chat box. You are supposed to tell modifications of TPs.
TPs. No answer?
Ma'am, we don't have any answer yet.
Not even. Acha, JR circuit. They have told. There is one has come. At least I'm happy that one has come. That is the JR modification. But there are many, there is something called as a KUN system, KUHN, where the hole is in the side of the bag. JR modification means you add a rat-tailed bag to the TPs. So in the KUN system, you have a hole in the side of the bag. Then the angle at which the fresh gas flow meets the expiratory limb, that can be changed. So the various angles can be there. Then you have something called as a Norman elbow. Then you can have a T-piece without an expiratory limb, or a T-piece with an expiratory limb, which has a volume more than the tidal volume of the patient, or that way you can have various modifications. And you can even add a valve to the rat-tailed bag of the JR circuit. So that way, there are various modifications. So this you will know only if you go into the depths of it. And then, of course, if you're doing very well answering the questions on the breathing systems, then I don't know, my favorite question is I do go into the history also. So a bit of history there. So if you have picked up McGill's circuit, you're definitely going to be asked what are McGill's contributions to anesthesia. So can anybody, can you go on typing the McGill's contributions to anesthesia? Dr. Monica, you can just...
Dr. Vinutha, his student laryngoscope. Then
yes.
Dr. Pangi McGill's blade.
Yes.
Forceps.
Okay. That's all. I think everybody is on McGill's forceps and the blade. Shall I add now to that? So this is how the examiner goes on asking you what's it, what more, what more, what more. So if you make a list and keep of McGill's contributions, then it will be very easy for you to answer. So McGill's forceps, endotracheal tubes, breathing system, straight blade of the laryngoscope, then the McGill spray, catheter mount, single lung anesthesia, bronchial blocker, bobbin flow meter. These are all his contributions, which so many you have missed out. Okay, this can come as a short note also, McGill's contributions to anesthesia. It's a very popular question of examiners. So like that, you should know the history of, a bit of history behind every breathing circuit. You know the flags, this one, the ISTPs. Can anybody tell me about Philip Iyer? Anybody has can tell me how anything about, you know, about who was Philip Iyer and what anything about him? No answer?
So the participants can raise their hands and I can unmute the one who is giving the answer. Please raise your hand if you know the answer.
Nobody. Okay. This is only something very inspiring. So Philip Iyer, he was an English anesthetist and he was born with a cleft lip and palate, imagine. And he lost his father at the age of 16 and his wife, she died soon after balloon mitral valvotomy. And he lost his son. He drowned at 7 years of age and with a daughter with cerebral palsy. So just imagine the hardships that he went through. But still he was so brave and he was very humorous. And he went on to give so many dental anesthetics. And he was the one who devised the ISTPs and he became the HOD of the anesthetics at Newcastle General Hospital. So this is very inspiring. I found it. So I just thought I'll tell you. Also, you should know a bit about that. Now, one question to Dr. Tushar. What about these breathing systems or breathing circuits which are seen in the modern anesthesia workstations? Can you tell us something about them? Like, are they different from what you told from the age-old ones, or there is something unique in something different in them?
These are nearly same, ma'am. What we are using right now on modern anesthesia workstations are the closed circuits.
Yeah.
With unidirectional wall which is enclosed on the workstation itself.
Yes.
Okay. And we have some add-on connectors, and we can add an HME filter at the Y-piece, and we have a sampling port at the Y-piece. So these are nearly the circle system is same. The modifications are inside the concealed modifications are there. Various concealed modifications are there according to the provider workstation which they are providing. So they will be having a O2 sensors are there, which are not included in our discussion, and was told that circle system and all those low flow will be taken in next. So we didn't get into details, but there are many additions according to the features which the workstation provider gives. There are flow sensors, there are O2 sensors, gas monitoring ports, humidification methods. All these add-on features are there in recent
Exactly.
circle systems.
Exactly. And there is, to add on to this, there is active warming also of the gases. There is active warming of the gases, and the circuits. Yeah, and the circuits are very compact. They're very compact, and those parts which are in contact with the patient gas, they can be autoclaved.
Yeah.
So these are one of the features. And then of course we have got the Draeger machines, which are different from the GE anesthesia machines. So in the Draeger machines, you have the fresh gas decoupling device. So anything you can add on the fresh gas decoupling device, like? See, because of the fresh gas decoupling device, what happens is that the chances of what happens is the additional fresh gas, it cannot be added to the tidal volume which is delivered, and because of that, the tidal volume which is delivered becomes more accurate, and there are less chances of barotrauma and less chances of volutrauma. So these machines like Draeger machines, especially Draeger Fabius, Draeger Zeus, they have advanced technology, especially the turbine technology which is there in Draeger Zeus, that provides an unlimited inspiratory flow. And one last question is regarding the HME filters. If you use the HME filters in anesthesia circuits, what are the problems like? Can they lead to any problems, technical problems like?
So if they can, if we are using HME filter, it can get blocked.
Exactly. Yeah.
So it will increase the work of breathing. And also, I would like to add some point about Dragon machines. If they are having, even if there is O2 failure, so in this Dragon machines, we will be able to give breaths on ventilator. That is, it will utilize room air, and we can continue ventilating the patients in case of Dragon. This is the add-on features which Dragon machine has. That is, if there is a sudden shutdown of O2 because of any reason, and if there is no gas flow in the system, this machine will take up the room air and the patient will be ventilated on room air also. So this
Dr. Madhuri, we will be taking up the ventilators in a different class.
Yes, sir.
Yeah.
Yes.
So
In the
I
next
think
class.
considering the time constraint, we should go for 1 or 2 questions here, whatever been asked.
Yeah.
Monica, you can see the question, the chat box, if there are good questions.
So some questions are, one question was, what is the difference between T-piece and universal F? Universal F or some.
Universal F circuit, yes, sir.
So universal F circuit is a closed circuit, and T-piece is a semi-open circuit. It is completely different circuit basically. So universal F is a closed circuit. Okay, if I can show you, I will show you the presentation also.
Closed circuit we will be dealing in the next class also.
Yeah.
Don't worry.
This question which one of the student had asked is, what is the difference between T-piece and universal F? In T-piece, it is a Mapleson system, and universal F is a closed circuit. It has an inspiratory, and it is a coaxial arrangement of closed circuit. So if we take this closed circuit, and if we are coaxially arranging both these tubes, it will become universal F circuit. Okay. So this has a inspiratory tubing. Expiratory tubing will be outer one, and this point will be a Y point. This will act as a Y junction. So this is completely different from T-piece. Okay. One more question was there. What is the dead space? So
dead space of main circuit.
Yeah, dead space. Yeah. So dead space of the circuits, I will like to tell all the dead space. So if we dead space of Mapleson A, B, and C will be from patient end to the expiratory valve. This will be the dead space. Okay. For Mapleson D, E, and F, the point at which the fresh gas flow enters will be the dead space. Okay. So this will be the dead space for other circuits, that is D, E, and F. The calculation will if the mask is attached, depending on the size of mask, the volume will differ. So someone can ask, how can we calculate the amount of dead space of the mask? It is according to the size of mass. It will vary. Okay. The main circuit is Mapleson D. So for Mapleson D, it is from fresh gas flow to the patient end. In case of closed circuits, it is from the Y junction to the patient end is the dead space. Okay. So for Mapleson system, from the ABC, it is from the wall to the patient. For DEF, it is from the O2, that is fresh gas flow entry point to the patient. And for the closed circuit, it is from the Y junction to the patient.
Thank you so much, sir. I think that is all. We only had 1 or 2 questions. So over to you, Bajwa, sir.
Thank you, Monica, for anchoring this thing. And I really appreciate the efforts taken by Dr. Tushar to prepare these classes, because this class was a difficult class. The circuits, actually, whenever we enter into the anesthesiology curriculum, the circuits really make you, having a headache almost every evening. A, B, C, D, E, F, then other classification, then the gas laws, the physics, and the Viva part, the table teaching, whatever we get during our PG is very difficult to imbibe everything. And he is perfectly described in a very concise manner and aptly supported by Dr. Madhuri, and she has made almost, I think half the Viva has been taken in this class only. So you can at least the examination part, I think, done. So this is the advantage of these type of classes where so many stalwarts come together and prepare you for Viva and the classes. Even I think when we were preparing for the entrance examination for the MBBS, the most difficult part was the physics. And when we got MBBS at that time, we were so much relieved that now physics we don't have to study anymore. Chemistry and biology, okay, that may be the extension. But when we landed up in anesthesia, this is a specialty where we study the physics maximum among all the medicals, right? From your gas plants, your this one CSSD or your OT or your ICU, a ventilator, circuits, everywhere physics is involved. And there are very good separate books for the physics for anesthesiologists. The class has also been taken. I think the physics is a never-ending phenomena for anesthesiologists. And every class will have some sort of physics involved into it, whether it's a monitoring part also. The physics will come everywhere. So we can't, get our दामन छुड़ाना बहुत मुश्किल है physics के साथ. लेकिन gas law जो भी थे, I think covered sufficiently enough, because rest the students can read from there also. And some part I think overlaps, they keeps on overlapping. There's just like the closed circuit and the low flow anesthesia we will be covering in the next class. And the mechanical ventilators will also be covering after that. So all these parts are very important for Viva and long questions, as well as, even on table teaching. And you can answer the short answers also during the examination. They will definitely come. I really appreciate the headache taken by Dr. Tushar and especially Dr. Madhuri also to teach in such a good manner to all the students. And I think we are quite late, but it was a very much required topic also. So with this, I think my best wishes to all the speakers. And one good thing is that all the people who are presenting the class, they will definitely get their certificates at the at the end of every 3 months. So those, I think we will try to sort it out to give some credit hours also to these classes in the coming days. This, just like the CME credit hours every weekly, so that whosoever attending the classes, they can apply for that. So let's work on that, and we will be coming with that modification also, just like the ISTPs has been modified. So right over to you, Monica, to close the session here.
Thank you so much, sir. Thank you, ma'am. Thank you, Dr. Tushar. So we'll be meeting on next Monday with a class on closed circuit. Till then, thank you so much for joining us. Good day.
Thank you, everyone.
Good night, everyone. Good night.
Good night.